All right, it is 5 o'clock, so let's go ahead and call the Kittitas County Public Hospital District #1 Board of Commissioners meeting for January 22nd, 2026 to order. For the agenda, I want to add under executive session, a discussion with legal counsel about current potential litigation and legal risks of current or proposed action, RCW 42.30.110, subsection 1, subsection I. So I just would like to add that to the executive portion. Does anybody else have any other changes, additions to the agenda?
No.
Okay, when ready, I'll entertain a motion for the amended agenda.
Move to approve the
Second.
amended agenda.
Okay, motion by Erica, second by Bob. Any further discussion? All in favor, say aye.
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 I too vote aye. Pat said aye. That motion is approved.
Matt.
Consent agenda. If you've had a chance to read through the materials provided for the consent agenda, I will entertain a motion when ready.
Move to approve.
Motion by Erica,
Second.
second by Bob. Further discussion? Hearing none, all in favor of approving the consent agenda, say aye.
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 Aye. No one is opposed. That motion passes. So now we are to presentations, and tonight we have Troy and Cindy from the Ellensburg School District. So the floor is all yours.
Thank you. Hi, I'm Troy Torn. I'm superintendent for the Ellensburg School District, and City Code, our board president. And so we really appreciate your giving us a little bit of time. We'll be respectful of your time as we just got done planning our board meeting for next week. So we know how challenging all of that is. I will skip through a lot of these slides as they get set up. Just purely information, as leaders in the community, we would like you to have kind of the high level look of why we need to renew our educational programs and operation levy. And so if people ask you as leaders, Erica's of course heard this before this week, you can shoot them our way. We're happy to talk about it with anybody, and we know that education is really important. So we have 8 campuses. We're just under 3,200 students this year, and an educational program and operation levy will allow us to maintain the same level of staffing and programs that we have for students. We have about 210 teachers and 271 support staff. And as I'm sure you're dealing with, and I'm not an expert in the healthcare field, but I'm sure you're dealing with the same type of stuff that we are, which is the state not fully funding certain things or putting unfunded mandates. And so that's where a big chunk of our levies go these days. What's known as the McCleary fix from a few years ago, the court case that changed funding for state schools, has not really fixed anything. We're actually back to a significant reliance on levies for basic education that was supposed to fix. The fixes in McCleary never actually helped the Ellensburg School District, just by circumstance. It wasn't, didn't work for us. So costs have gone up significantly. Inflation is really a big part of our levy stuff. So here is where McCleary fix did not help us, just so people understand this. They now give us a flat fee for each teacher. There used to be what was called staff mix. So if you had a more veteran staff, you got more money for a teacher based on your enrollment. Now that it's a flat fee, we have an extremely veteran staff in Ellensburg. So we have a gap between, we have a competitive salary schedule, but we don't have the highest salary schedule in our region, but we have a gap because of this experience factor. So our levy is really important from that standpoint of that's how we pay the gap. And if we had to pay that somewhere else, that would be taking money away from basic education. So our experience is great, except when it comes to this accounting issue. So here's our cost increase. The hospital has dealt with the same thing. We're up over 21%. Utilities, I was ever grateful we presented at the city council. Heidi Turnaway let me know 3 months in advance how much gas was going to go up for us. But we're dealing with that. Our liability insurance is incredible. We are a tier 1 district, which means ours is going up at the lowest level possible, but it's gone up 15% each of the last 3 years. We don't have a major claim. So that money and the money that the state provides us, which is known as MSOC, maintenance, supply, and operating costs, supposed to cover this. It certainly has not risen by 21%, or excuse me, by 15% per year. A dumb one, that's not that much money, but it shows how we all, as public entities, get nickel and dime. We get audited every year. we also get the joy of paying for that audit every year. And so the state auditor's costs have gone up 6% each time. So that's not a ton of money for us, but these types of things add up. And the professional services. So when we are contracting for nurses, or we're contracting for speech and language pathologists or occupational therapists, because a lot of those positions we can't fill a full-time person, and they're hard to get, and so we contract. Those have gone up an average of about 15% each year as well. Now, also this year, based upon what the state legislature did last year, starting January 1st, we also get to pay sales tax on those contracts. Now, they've said they're going to take us out of it, so we weren't supposed to be in it, but we'll see. We've got a few more weeks left. But all of those are just examples of things where our expenses are rising, prices are going up, and we are not getting that requisite from the state. So MSOC funding has gone up. Well, let's just put it this way. We spend $4 million out of our levy for MSOC, that more than the state provides us. It's gone up. MSOC funding has gone up about 1.5% for the last 3 years, where our costs have gone up significantly more. Those costs won't go away. So if we were to not have our levy in that level of inflation, we would have to take it from basic education, which is a challenge for us. Here's explaining, all the money, and we have tried very hard to make this a replacement levy. Of course, it'd be collected in 2027. So our estimate of our rate is there. It was passed by the community 4 years ago at an estimated rate of $2.50 per thousand. We're running it at $2.42 per thousand this year, and hopefully we've done that. Lastly, this is a generic, so you guys see some of our kids there, a piece of the pie, explaining how assessed value works and things like that. Here's a list. It's long, but there are other things besides it. Some of the things that are really important to us in our community that we are unique to Ellensburg and are amazing to have an orchestra program. It's extremely popular with staff, students, families. It's also very expensive. It was originally started as a grant from a family, but that's gone away. So we are taking that on, and there is essentially no state funding associated with that. That would be purely levy. Music in our elementary schools. We have 4 elementary schools, but our apportionment, the number of kids we have in each one, doesn't necessarily drive a full-time music teacher in each one. So we use levy funds to fill out some of that staffing and things like that. Instructional materials is a big one for us. That should be a part of MSOC. Once again, it has not kept up. We're doing a literacy adoption. It's a big year for us. We're adopting literacy materials across our district. And we have already budgeted twice of what it cost 6 years ago, because that's what the expenses are. We're a subscription economy now. I was talking about everybody has a smartphone. Apple doesn't make the money on the head. They make the money on all the subscriptions and those types of things. The educational materials world is doing the same thing to us. So we don't just buy a book and then 7 years buy another book. We buy the book, but then we have to pay each year to access all the support materials. So that's what's really driving up our expenses there. Highly capable program. The state funds that a little bit, but it does not even come close to funding those types of things. So there's some examples. I will also say special education has been paid for a significant amount of the levy. The state has given us some support with special ed over the last 2 years, far more than MSOC. But we still spend for our most high need students, we still spend about $1 million out of the levy. The legislature gave us those increases, doesn't want to hear it anymore. So they said, we've now fully funded special ed. You can no longer use levy money to pay for special ed. We still have those expenses. We still have some very high needs students. And so we will just be taking that extra out of ed and then paying for something else out of the levy. It's a shell game. So it's still very important to us. So I'll kind of just allow Cindy to kind of give the board perspective here at this point.
Thank you for having us. I guess I would just like to say that I think of the levy as our local share, supporting schools, which, like this hospital, make Ellensburg a fantastic place to live. It allows us to recruit families, to keep them here. And we take this money very seriously. The board has been very cautious, very conservative and conscientious about how we spend it, really thinking about how generous our community has been and how much we appreciate it. So the board, has thought long and hard about making this a replacement levy in the sense of just continuing the 4-year levy that we've asked for and historically have been supported by this community, which we really appreciate. Thank you.
And then just to sort of, that's it. Here's one series of unfunded mandates that impacts our levy. And I use this as an example because not everybody knows this. So this will be the last thing I sort of leave you with. By law in Washington State, all of our full-time employees, whether they're certificated or classified, by law is allocated 12 sick days a year. The state pays us for 4. So they reimburse us for 4. So all of our substitute costs in this total number last year was $1.46 million. A small percentage of that is our choice, right? So we pull people out for professional development, things like that. So the state reimbursed us $92,820. Most of that's sick leave, which is required, personal days, which we negotiate in the contract and have to pay for that levy. So that's our choice as well, but paid family medical leave. And so that is a big challenge for us moving forward as that number continues to go up. So that's one I was surprised at that number. So thank you for your time. Please let us know if you have, any questions at any time. Hopefully as leaders in the community, if people ask you, just send them to me, send them to the district office. I'll be happy to meet with anybody and talk about it. So we appreciate your support. And as Cindy said, Ellensburg is a pretty cool community. And so it's the support of how we all work together. So thank you very much for your time.
Any questions for either of them?
I have none, but thank you for coming.
Yeah, thank you. Appreciate
Thank you
it.
for having us. We appreciate it.
All right, so next we're moving on to David Johnson at JJCA with the master facility plan presentation.
Thank you, everybody. I've got a few slides I'll share to kind of help structure, but my intention is to go through these fairly quickly for you since I know you have a very full agenda and be able to have time for any questions that you may have. And it shared the wrong thing. You can test all this stuff all you want till the time comes to share screen on screen 2 is what it should be. I'll drag it in here. Screen 3. Okay, there we go. So nothing earth-shattering in the slides, but just to help hit some of the points. So I do appreciate the opportunity to share with you tonight kind of what we do and how we approach it. I understand from last month there was some specific questions about the process. So we have refined this process over the last 30 years, working across the country in rural communities with critical access hospitals. We've done several hundred master plans and then worked on implementing those because that is our passion. While we do a lot of healthcare, almost all of it is in rural communities. And so some of you may know Whitefish Hospital in Montana, in Montana, then Cody Regional Medical Center in Cody, Wyoming. We've worked with Whidbey Medical Center, Ferry. We've worked for a long time with Gritman Medical Center in Moscow, Idaho, and others. And we really focus on 3 things. It's very hard, as you know, to get capital. And so we're working hard to maximize the impact the capital will have, both on the transformation of your community and how they view healthcare, but also on that return on investment. Where do you put the money to generate better care and generate revenue so you can continue to make those investments? We also focus on the community that we're working in. We don't have a one-size-fits-all solution. We really look for what is important to you, what does your community needs assessment say, and then just the feel of the town and what that says and how that should be a part of the hospital. And then generally that leads to us being kind of long-term partners. So we become a resource. When today I was on a phone call, they're going to replace an X-ray piece of equipment. It's a room that's been there 20 years. And so just what changes do we have to make? It's a very simple piece, but they needed some insight and guidance on what to do. So the way we approach master planning is we look at it, and our goal is to help you make high-level decisions, spend the money the right way in the right priorities, while maintaining it as a roadmap to the future. It will change. It will vary over time because your priorities will shift. But it gives us a roadmap that we can always look at and know that we're not leaving anything out. And I think one of the things that's very important, we do this with your staff. So it's with the departments to not only hear what they need, but also to educate them about what we're seeing across the country, what we hear is coming in the future, and to get their buy-in without letting it turn into a wish list. And that can be difficult at times, but we will challenge them on, why do you think you need that? Where does the data show you need that? And so the steps we go through is first to kind of look at all of your planning goals, the sites that you have. The second step is to put together a space allocation program. This is a very detailed listing of all of the rooms it takes, whether your hospital is brand new on a new site or it's modernized where it is. It's everything that's required to deliver the care to your community in a transformative way. Then we look at solutions. So the second step we call the problem. That's the problem. That's what we need to solve. We need these spaces. Third step is to look at the solutions and then to put comprehensive budgets on them for you and present those back to you. As a part of the first step, we will often do a financial analysis that lets us know, kind of with a target, what can you afford to spend under the right decisions. It's not to spend all of your money. It's to make sure that we have a plan that you can afford to implement in ways that make sense. For some of our clients, they may be able to afford $80 or $90 million, but the board is only comfortable going to 50 or 60 because they don't want to spend everything that's on their credit card. Knowing those things up front avoids having a master plan that cannot be implemented. So as I said, we're looking at the community issues. What land do you have? What restrictions are there? We look at current volumes and future growth. What capacity will you have? And that's a little different analysis in a critical access hospital. And then we look at your infrastructure, meaning your mechanical, your plumbing, your electrical systems, condition, remaining life expectancy, because we often find replacing equipment leads to architectural changes. Looking at one today, and they had to add outside air units in a building that's about 20 years old. And all of a sudden we need a room that's 10 by 8 taken out of an existing space. Well, there's not a lot of extra space around usually. And so it's understanding what the infrastructure does to the plan so that, again, the plan can be better. The space allocation program is that detailed listing, and I'll show you an example in just a minute. But here's why we do it, is to get the detail and to challenge them on needs and not wants. And it also will let you as a board know, where is this space going? Why does this building need to be this size? So when people in the community ask you, you will have those answers. This is an example of a page out of lab. And so it has very detailed listing of the equipment, how much square foot each piece needs, every room, what goes in those rooms. So it's not just blocks that say it should be this big. Here's why it needs to be that size. Then we do solutions. We do those on site with your team. So we spend about a week creating the program document, and then we spend several days to create a rough concept of how it would work. Not only block diagrams that show departments, and we show staff how we move patients through, supplies through, ambulances to the ER. Our plan somewhat uniquely also behind them a very detailed plan that's almost a schematic level. This plan has every room that's in that space program. So we know that the shapes that we create actually work functionally. And that again makes the plan better at implementation. Then we'll create presentation level drawings that people can see. Then we have to put a budget together, and that's a key component. Our budget, we try to make sure includes everything. It's got medical equipment. It looks at the variation of cost between, say, a surgery department and an administrative area. We look at the future inflation rates that are expected. We do it on the timetable because that goes into the inflation. All of those things go into it to make sure it is an accurate budget. We will budget it in lots of pieces. So this is a sample of one. Every one of these columns is a different piece or phase. We found over the years that if we break it up to start with, then you as a board and leadership team say, well, we really need to do this one and this one and this one. It's as somebody once told me, it's easier to scramble an egg than unscramble it. So we'd rather break it apart. And that gives you a granularity of detail to know not just the whole thing cost, in this case, 72 million, but that piece cost 3.7 million. And you can then make judgments about, is that really worth it or not? And those budgets going to include construction cost, which is what most people talk about, what we call project cost, which is the added piece that covers fees, furniture, technology, medical equipment, all those administrative costs, building permits, Washington state taxes, all of that stuff gets added on the construction cost. And then we do the financing costs, because as a board, you have to approve everything inside the red circle. Some people forget this financing transaction cost, and then they're having to come back and ask for more. And we will remind the leadership team and you, there's a thing called opportunity cost. If you start a new service as a part of this plan, there is an opening of a new business cost, just that startup staffing, initial supplies. Those generally are not inside of what we deal with, but we don't want you to forget them because they impact your operating budget when that time comes. And so that's kind of our process. With that, I'll answer any questions that you may have.
And David, we have a helicopter taking off, so just be aware of that.
Okay.
Any questions for the presentation? Anyone?
So are you gonna show them the last one that we did?
I don't, there's been no discussion of that I'm aware of. I'm control on it, so everything is best and stuff, so. Yeah, I don't think, I'm not hearing any questions here in the audience so far. Is there anything else you want to share with us? And why don't we hold for a few seconds while the helicopter actually lifts off?
Okay.
Talk amongst yourselves.
So what
All
I
right,
learned,
it's
what I
getting
learned in
quieter
this
again.
call is that a key question or key requirement is that you have a boardroom that doesn't get interrupted by every helicopter coming and going.
So, yeah, so I think we've got a pretty good understanding of what you're suggesting. And so we really appreciate you taking the time tonight to present to us.
I appreciate the opportunity. Thank y'all.
Yeah, and we'll be reaching out soon. Thank you.
What's the timeline?
Okay.
What's real quick, I have a question in there. What's the timeline based on what you know about our facility?
Usually these processes take about 3 to 5 months from the initial kickoff until the final board presentation. It is a little bit dependent on people's availability. You know, getting the staff that we need in the right place at the right time with everybody's work schedules can sometimes require us to wait a couple of months just to get on people's calendars. The actual work takes about 3 months if we can move through it fairly quickly. But
Excellent.
we
Thank
tell
you.
people it can be up to 5 just because of those issues.
Yeah, no, I appreciate that. And Matt, you popped up momentarily. Did you have any comments?
Nope, sounds good to me.
Okay, good. Thank you.
All right. Thanks, everybody.
Thank you, David. Have a good night. Relinquish control. So moving on, we're going to have a spotlight. Does anyone like to introduce the spotlight for tonight? Jason?
Yeah, I'd introduce Cody Staub. So he's our ER director and going to give a presentation about our ER and the work that he's done to bring a residency program here. Holly Urban wanted to be able to make it tonight, but she had to catch a flight out of town, unfortunately, so she'll miss the presentation, but very supportive.
Welcome, Cody.
Thank you. I will. Just so you guys know what's passing around there, I brought some instructional goodies. So that's part of our residency program as I'm talking. You can look through it. Thank you, Cody.
Blacked out. Oh, there we go. Okay.
Okay. You have to stop screen sharing. Sorry, there we go. The quiz goes around here.
All right. So thanks for letting me highlight this. This is a really exciting thing for us. Just kind of dive in. So the problem we were facing a little over a year ago, we had basically had no night shift nurses that were employed. We were all travelers and all people filling in shifts. And that had gone on for about a year. We weren't finding qualified applicants to fill these. So I noticed we had lots of applicants who were new, but we hadn't really done training on new to practice emergency nurses very well in the past. So we're really hesitant to hire those into a night shift where you have limited resources. This is just a quick thing on kind of where the state of emergency nursing is. And so in 2023, that's the last data ED nurses have about a 22.4% turnover annually. So almost a quarter of your staff is turning over in a normal ER right now every year. And that just keeps going up.
And do you know, is that leaving one facility, but just going to another, or they're leaving emergency care altogether?
Emergency nursing. Yeah. So it's a high churn profession, especially right now. And when I figured this out, it was costing us about $90,000 to train a new nurse here. So this is just a list of reasons that nurses give for leaving the emergency nursing profession, and that's not specific to us, but I think a lot of these feel familiar to us. And these are kind of in order. So this is what nurses list when they're surveyed about why they leave. And the bigger challenge, if you're bringing in a new nurse, is you're going to spend $90,000 to train someone, and then 10 months in, they leave. And then you're just doing that all over again. So in nursing, this is the first year problem, is we have a huge number of nurses who leave in that first year if they don't feel supported. And if you can keep them for a year and they feel supported after that year, then you have a lot better chance of keeping them. So the solution to this really is investing in education. There's a lot of research on this, and that's where this program comes from. And this isn't specific to ED nurses, but nurses will remain in positions even for less money if they receive substantial support in education and professional development. So this is, what continuing education is. It helps enhance your competency. It makes them feel better with their job. We're able to provide patient care. And that's what really encourages your retention. So this was kind of our solution that we brought forward and approved last year. Yeah, last year now. So nurse residency programs, they're all over the place. You can find nurse residency programs. It's a very popular thing right now in nursing education. And ANCC has recommendations, Magnet has recommendations on having transition to practice programs, things like that. So it's kind of a big moment for residency programs. These are the kind of things that they support for employees as they're learning how to be a nurse in this environment. So we chose in the emergency room to go with the Emergency Nurses Association's residency program. So ENA, just real quick, it's a professional nursing organization. It's the professional organization for emergency nurses, and it's a little bit unique in that a lot of professional organizations are like all leaders or all bedside nurses. ENA is a really diverse organization. That it's about a third leaders, a third educators, and a third frontline nurses. So it's a really good mix of nurses, which makes sense because emergency nurses kind of do a little bit of everything. So it is very, very evidence-based. ENA took out a whole bunch of studies to study exactly what it is they wanted to put into it. And it's very comprehensive. So something that it does that other residency programs that we have tried and also have looked at, things it does that others don't. It trains your preceptors. And that was really important because we haven't always put a lot of effort into training people who are then going to train others, right? And that's really a crucial piece. So this trains people. It has a lot of content on how to communicate and foster collaboration in a learning environment. And it has a lot of, like I said, communication pieces. We'll get to that a little bit later. So it's a really holistic program that is really turnkey and you can just drop in. That was also really important because there are other programs out there, but you have to put a lot of effort into making it yours. And this one was pretty easy. Well, I say that in air quotes, easy to implement relative to others. This is really like tip of the iceberg, what's included in this platform. So it comes preloaded with 15 didactic topics that range kind of all across the spectrum for caring for an emergency patient. It includes the agendas, the slides, notes, recordings, simulation recordings, just a whole plethora of things for each content. There's also training for the instructor. So that's a whole separate piece that you can assign our instructors how to teach this content. And there's a whole thing for that. There are over 30 case studies. Those just keep getting added too. So there's lots of case studies and it's not just like a piece of paper and talking about it. It's engaging content, recorded lectures, back and forth kind of stuff, videos you can use. There are 17 simulation scenarios. We didn't get to do as much of this as we would have liked, and I'll talk about that later in kind of learning lessons. There's also a whole set of self-paced modules. And these are kind of like our health stream that we're doing now. They're learning management. They can do them asynchronously. They can do them at home. What we did is set them up for time here where they could do them so they weren't doing them at home on purpose. And then there's the resident workbook that just is passing around. And that goes along with, and it's not required or anything for them to do. It just is an extra. With that workbook, there's a whole online program that goes with it, helps support nurses who maybe are struggling or learn things in a different way, and a whole like YouTube series that goes along with that. How to learn this content, how to learn this content, how to learn this content if you're struggling. So, and that again, tip of the iceberg. There's so much more, but we're going to keep this short. This was a huge lift for us, even though it was turnkey. I put the map up there because the purple dot that has the circle around it, that's us. We were the first hospital in the state of Washington to adopt this program. Valley Medical Center just launched it. I think they're launching it this month. So they're on the map now too. But we're the only two hospitals. You can see the purple dots. Those are all the other ones. This program's only been launched for 3 years, I think. So we began in March. We had a big team come together, plan out what we were going to do, who was going to do what. When I say the entire hospital, it wasn't literally the entire hospital was involved. And we had support from KVFR. So they helped us out with a lot of things too, from classroom space to an instructor to come help teach one of our modules. And our nurses did some ride time with them as well. We had 14 instructors, all said and done, and we had 6 preceptors that worked with 2 students. So this was kind of our outcome. These are our two new grads. Well, they're not both new grads, but they're new to ED nursing. So Ashley up there came to us from Rob Everett and has been a nurse for 2 years, but brand new to the ED nursing environment. And Katie has worked here as a tech, but was brand new as a nurse and to the ED environment. So we took both of them on. They went through a 6-month residency. 36 hours a week, working one-on-one with people. I will say that I think we set them up for success better than we've set anyone else up for success. And I'm very happy with how both of them are doing. They're on their own now. They're working actually both of them tonight. That's why they're not here, because they work at 7 p.m. But we're now actually fully staffed on night shift too. So we converted one of our travelers. We had someone else out of a residency from a different facility that came to us and is kind of at the same level. So it was a really nice hire. And we're doing pretty good right now. That's a constant flux turnover. So I'm anticipating what's next. We're doing an in-person preceptor training for hospital nurses on March 4th. That's the plan right now. And the cool thing about ENA and the way they license this is the content we have is available. It's not a per person. We get the content and we can do it for whoever we want. So they're coming out to us to do a workshop with nurses, with their experts. And we can have any nurses in our hospital who want to learn to be preceptors because it's a more generic concept to come and do that. So that's pretty cool. The residency, the way we purchased it, includes year 2 and 3 content for these nurses. So it doesn't just end after the residency. I have more modules and simulations and things that we can do with them that go over transitioning into a charge nurse role, transitioning into a preceptor, sexual assaults, all sorts of concepts as they go on that helps them grow over time. So it has a professional development component to it as well. And then we are using this already to impact how we're training new nurses in other areas. So we have a nurse in CCU right now that's going through a transition to practice type program and purchased what are called the ECHO modules, the ICU training modules, but they're augmenting it a lot with this content too, and kind of using these concepts to figure out how they're going to train other nurses who are new to an area. That was a lot, and I tried to keep it really fast for you guys. So,
Good job.
what questions do you have?
So will this program, so Katie and
Ashley.
Ashley, are the first 2 nurses to go through this program, are you running a version 2, or will that be as needed? Is it going to be on a set cadence? How do you decide that?
Yeah, so that's what we're looking at now. Oh, and I forgot I had this one slide. So yeah, we are learning and improving for another cohort. So that's what we're actually looking at right now. And the exciting thing is we have this clinical excellence department now, which we didn't have in this form when we started this. So I've been working with that team and they're kind of diving into figure out what can we do regularly on a timeline, who's going to own what, all of those kind of things. So they're kind of laying out plans. I'm anticipating that we're going to do this once or twice a year at least.
You already answered the other question I was going to ask, is whether this could be a template for other departments. And it seems like that has been an obvious choice to use that. It's going to speak for itself that that would be something we want to do.
Yes.
This is really fantastic.
The other really cool thing about this is we probably won't do this, at least right now, but it's one of those programs that can be certified as a residency. It's kind of a thing from American Nurse Credentialing, so that we actually have a program that would meet the credentialing requirements for a transition and practice residency. So.
Thanks.
Any other questions for Cody? Really appreciate it.
Yeah, thank you.
Very informative. Thank you.
This was all you that brought this here, so thank you.
Well, thank you. And we definitely have lessons learned. I don't want you to leave thinking this went perfectly, but it's been a lot of fun.
So we do too have two highly skilled nurses working
Yes.
right now.
So should we do a field trip downstairs to say hi?
Like the sidebar
It's
upstairs.
not a bad idea.
Thank you.
Thank you, Cody.
Thank you.
Thank you, Super Cody.
All right, we're moving on to public comment and announcements. Is there anyone here in the room that would like to make a public comment? Okay, hold on real quick. Is there anybody online that would like to make a public comment? Okay, seeing none, let me read this quick then. It's a new year, so we're gonna do a little bit more formal public comment. So I want to let you know, members of the public are asked to state their name and address prior to stating their comments. Each member of the public will be allowed a maximum of 3 minutes for comments. Mandy will hold up a green sign when you have 20 seconds left and a red sign when your time is up. Dr. Larson.
Mark Larson, 815 East First. Thanks for allowing me to speak. I'm wearing my health department hat today, although I have lots of hats that I wear. And the first thing I just want to say, that we're currently dealing with the measles outbreak, as you all well know. There's 6 people in this room that have been actively involved in supporting the health department. Our health department's a very small department. We would not be able to do what we've done, both with COVID and now with this measles situation, without the help from the hospital. So I want to say thank you. Over the years, the hospital has taken some of our people, so we kind of view that as kind of, we've infiltrated the hospital a little bit. So it's actually super helpful for us. So background, we have 1 case of measles, a young person who was unvaccinated, traveled, was exposed, came back, worked at Central, went to school at Central. The biggest issues we've had, and we've not had a second case yet, but we've got another until mid-February before we can say we're not going to have any more cases from this. The biggest issue we had was really tracking down people's immunization status. So 110 close contacts. So the person worked in the cafeteria. So we have a bunch of people, thousands, that were exposed in our community that we don't know. But we had 210 people that were considered close contacts. We, over the years, have tried to convince Central to keep track of who's vaccinated and who's not vaccinated, not pushing, you have to be vaccinated, but it'd be sure nice to know if you were and were not. We had to remove a lot of people, 22 people out of work and class until we could figure these out. And when you're working with students, as my wife would tell you, they don't answer their phone, they don't answer text messages. So to get compliance with people just letting us know whether they were vaccinated or not, we actually had to send our health department nurse with the campus police with a letter that said, if you don't call the health department the next day, there will be legal action taken. It was kind of a waving the flag of this is an important piece. Thanks. So we have 3 people that we're currently following them. So that's out of those 210 people, we have 3 people that are unvaccinated that are at risk for getting measles. But again, we have this whole community group that's out there. And so we'll continue to work with you. My time is up, which is great.
I would just say,
It's nice
this
to have
is
3
not
minutes.
normal public comment. This is for the good of the public.
Just let me suggest, this might be where an amendment to the agenda to
Yeah.
add a health department update.
Speak as long as you
Yeah,
need to
well-
speak what you want to say.
So we'll continue to need help from the hospital for
Yeah.
sure. I mean, we have 1 nurse, we have 1 medical assistant. We pulled a few people. It's taken about well over 120 hours of tracking, of doing case and contact investigation to try to get these. We don't like to use the big stick as a tool, but using the campus law enforcement was really a brilliant idea, which was not mine. The campus president's been real supportive of this. So we're going to use this as a tool to encourage all of our schools to also gather all their immunization records, not for just the students, but also for the staff. Because that's a big issue, because all those people that we didn't have their records, we had to say, you have to be off of work for 21 days because we don't know whether you're immunized or not. We have 19 of those people that only have one MMR, so we are going to have the caravan, the state funded van come over, and we'll be doing a MMR vaccine for the community. So I'll make sure to let you all know when that happens, because there'll be people here that only have a one. There'll be people that work here that don't have any. So I think we're going to use this as a tool, and hopefully we're not going to have any more cases out of this, but I'd be surprised. And I'll be really surprised if we don't have more measles outbreaks in the upcoming year. So, and I'll take any questions, but really it was just a thank you for everyone that's worked in public health.
For those people, like, I was born in the 70s, so those people who are maybe more vintage and their vaccination record is on paper and who knows what happened to it along with their baby book. What advice would you give them as far as determining or being able to demonstrate if there is an outbreak and somebody says, hey, what's your vaccination status? What should these people do?
We had a person who was one of the directors up at the campus cafeteria that fit that exactly. We went to her mom. Her mom's still alive. Her mom went to the box, to the shoe box, got out her records from when she got vaccinated at Kittitas Elementary School when she was a kid. So those things. So some people's parents have kept all that stuff. We will help people with that. And then somebody who says, I know I was vaccinated. I don't want to be off work for 21 days. We get a titer on those folks. The rest of us, like me, we don't need a titer. Plus, I was born in 56, so I had measles as a kid. So,
And I'm trying to recall titers, they are not enterable into the immunization database.
they are not. So it would go, you would say, I have a titer, and you'd keep a paper copy, I'd recommend. We've had a few people have titers. A testing piece, we haven't had to test more people for measles, but that will happen, I'm sure.
So for those people born before the 70s, is it good for life once you get it?
Mhm.
Okay, good.
And those people who are born more recently, I've heard about adult children and they don't like to come to the door, but if you knock and say like Grubhub, they will open the door.
Yeah,
That's it.
that one works too. Yeah. Yeah. So in those people with one vaccine, they're pretty well protected too, but we are following those 19 people with one vaccine just to make sure. We're calling them every day and asking them for symptoms just to make sure, but they're mostly protected.
Is that in the 90s or is it 80% success?
Oh,
efficacy
it's above 93%.
for just one?
Yeah, just have one.
Powerful. Okay.
Okay.
Well, and for future reference, when presenting the organization, just let us know. We'll add you to the agenda.
Yeah, that's okay. It was really just, I was talking to my director. I said, I'm gonna go to the board meeting.
We really appreciate
Yeah, thank
it.
you
Yeah.
for showing
Although
up.
when you said 6 employees, I thought the next word was going to be
Have
have been
measles.
exposed. And they're in this room. You guess which 6.
Hopefully that won't happen.
So thank you for the
All right,
information. We
thanks a
really
lot.
appreciate it.
Appreciate it.
Yeah.
Thank you.
Right, if I ask a quick
Oh,
question
Matt's
here,
got a
Dr.
question.
Larson?
Yeah, you bet. Matt.
I'm just gonna turn off my video because it's a little unstable. So I think in our patient portal, our KVH patient portal, we can put in our vaccination dates and things, the vaccinations we've had. Would that suffice for something like this? Like, do you have to prove it, or is it enough just to record when you got the vaccinations? And KVH then would have that on record, but it would be self-reported in some ways.
If you're talking about ImmuAir, which is our employee health records, when you put something in, it has to be reviewed by an employee health nurse who says, yeah, this is valid or it's not. And we have criteria for saying, yes, that's acceptable. So it gets signed off or it gets rejected and you have to provide more documentation. And we do titers on folks that don't have enough documentation.
I was
Or who-
talking about like just patients, not employees.
Oh, patients.
Yeah.
I don't know if you
They
can
look
enter
nice.
your own vaccine portal.
Okay, I
usually-
thought I have, but maybe I'm mistaken.
There's a similar process with the portal though, where when they used to have the patient forms where you could fill things out, it has to be accepted by the clinicians before it becomes integrated into the record. So actually you probably put it in and it didn't do anything.
Okay,
So usually we have people, of these people that didn't know their records we've had, as soon as we can get somebody's date of birth, we can look it up on the state database, and that's a really helpful tool for us. People that are from a different state, it's a little harder. But
so I should have my mom go look in the shoebox. Is that what you're
you
saying?
should. There's probably really good stuff in there.
Okay, thank you.
Thanks.
Thanks again. Appreciate it.
Thank you, Dr. Larson.
All right, anybody else want to offer up public comments? Person or online? Okay, seeing none, we will move on to reports and dashboards. First up, Mandy with quality.
My report's on page 11. It's brief, like talked about it. Maybe. And I don't really have anything to add about my report, but I did want to give a quick update. A nice segue from Dr. Larson. It's not just measles we're worried about right now. So Anna shared with me some of our other respiratory illness stats. So for the month of January, we've had 71 positive flu tests. So that can be inpatient and outpatient. 9 admits or transfers and 1 flu death in our county. What we're seeing right now is about 18 to 49-year-olds are the most affected. And of those positive tests that KVH has seen, where Anna can see it in their chart, 18% of them are vaccinated. And then besides that, they're having to deal with measles. The health department has also put Mountain View Rehab in outbreak status for RSV. We've had 14 RSV cases, positive tests since in January, and 2 admissions. So that's a bit. And then on top of that, we had 1 each of a rhinovirus and a human metapneumovirus pediatric transfers out of our hospital. So transferred to children's with those diagnoses. And we've had staff out with positive COVIDs. So there's a lot of respiratory illness going on right now. One of the challenging things for our clinicians in the hospital is that RSV is they each have different contact precautions. So we've got respiratory or droplet precautions for influenza, contact precautions for RSV, and then we've got airborne precautions for COVID. So it's a little challenging for people when all these things are coming in the door and they kind of look the same, and making sure that we're protecting other patients and our staff. For the working, it's challenging. They're doing your job, but it's a little scary out there. Wear your mask if you're not feeling well, or stay home if you're really sick, and wash your hands.
And those flu transports you talked about, is that because just the amount of care they need?
Yep.
They need to go
For
to a
higher
more
level
higher
care.
level.
They're so sick. Yeah. That's a lot.
Yeah.
For us.
Any other questions for Mandy? I was going to ask about the hospital acquired infection. It says 1 surgical site infection after a total knee. And so this person came back, had an additional surgical procedure and wound care visits. How does it work from the insurance standpoint or the cost standpoint to the patient? They come in, they get a procedure, they acquire an infection, which requires more care that was unexpected.
I believe we're not allowed to bill them for that, and we have, but
So they don't carry that burden if it wasn't their fault, and we try to make
Yeah.
them heal it
right.
and stuff. Okay.
Even if they did things like wore too tight of jeans and didn't follow cautions, but I know for things like falls, if someone has a fall in the hospital and injury, we can't bill for that.
Okay.
Yeah.
Good, thank you.
Follow up on it, Dustin.
Yeah, they'll deny some of the charges, but they'll pay. some.
They being the insurance company?
Yeah. But everything's still billed. Insurance company will monitor those and deny or appeal. And
We have to bill.
we appeal and we fight for every dollar.
Yeah. Okay, just interesting.
They're also, since we aren't reimbursed by DRG, it'd be a difference as well. So.
Okay, well, thank you. It's very interesting. Anything else from Andy? Thank you. Move on, Chief Executive Officer, Jason.
Yeah, thank you. I just want to call out because Amy Bloodworth is online here. She's been busy this last month. We did a incident command for having our telemetry system acting up. And then we also just have had a couple of just-in-time huddles to help be prepared for testing for potential measles patients. And Amy's been at those meetings, helping take notes and helping make sure we're prepared for emergencies in her new role as our emergency preparedness coordinator. So thank you, Amy. My report is very, very similar to 2 weeks ago. I don't have very much to update on other than probably a couple things I'll steal from others. We started seeing patients in podiatry January 12th. Things are going really well. The building design has been very optimal for patient flow and also kind of expanding contracting services. Podiatry can move into ortho a little bit. Ortho could move into podiatry a little bit if they need. Still recruiting for urology, but have some really good candidates that Janine's team has lined up for us. And the nuclear medicine program, Jonica, is still working with Dr. Nyack and the radiology team to bring online. Just included a few key dates coming up. So reminder, I'll be going to Olympia this next Wednesday and Thursday, joined by both Bob and Erica for the WISHA advocacy days. And then just have some events there at the end of my report that we're working with community relations to do. But one, just to have the board mark the calendars for April 1st for our provider appreciation banquet. It's not a April Fool's Day themed that I know of. Not yet.
Any idea of location yet?
I don't know. CW is typically where we go.
Yeah, we had originally a reserved circ, but it looks like we may be looking at moving it, so we'll get you a final answer here soon.
Well, that is all I have, but open to questions.
You note Scrubs Camp on the 24th of April and the Experience Healthcare in July. Are those similar type programs? One only being a day, or what are they different?
The camp is like 7 days long. And where we really bring people in.
So the Scrubs Camps just says April 24th from 8 a.m. to 3 p.m.
Sorry, I was thinking of the experience.
The experience is a week long, it looks like, yeah.
Yeah. Yeah, so the Experience Healthcare is a week long. We're inviting students from all throughout the valley. But it's really the work that Kyle and Crystal and them are doing to really go and reach students at an earlier period and help show them opportunities in healthcare. It's been something that's been really, I think, a success, but it takes time to see that success.
Excellent. Any questions for Jason? All right, anything else for us, Jason? No? All right. So then we'll move on to Janine, Chief Human Resource.
So we just did a year in review and we tailored it so that it aligned with our strategic impact and the work that we were doing for our strategic plan and how that worked. And just to tailor off of to tack on to what Jason was saying about Experience Healthcare and the work that they're doing. Our volunteer growth was pretty extraordinary as a result of that, and our student growth, which then translates to future employees as well. And so I think, having that connection between your student outreach and then your apprenticeships and your residencies and your clinical rotations, and then that translate into, full-time, long-term staff. I mean, that's kind of the full circle connection that we're trying to make. That's pretty exciting to see that all kind of coming together. And we're actually starting to see the fruits of all that labor. So that's pretty exciting. And then just the infrastructure to support our leaders to lead through all those change with the leadership competencies and the Just Culture rollout. And then how that will dovetail with our future leadership development growth. And you'll see a lot more of that reported out in 2026. We have our kickoff with compassionate accountability. We have a half-day retreat for our leaders coming up here in March. Is all I have. If you have any questions?
Question for you about travelers.
Yeah.
When they convert to permanent employees, do we get like a nasty grant from the agency or?
How's that? You know, the beauty of that was when we went with Before Health, is they negotiated that right up front.
Okay.
So that we don't pay big finder's fees for that. And that is the power of group purchasing and the wonderful thing about the collab. So when Jason was advocating for that early on in 2024, and that just had some huge impact right away. Our ability to control the cost of the agency utilization in the moment, but also those conversion fees were all but wiped out as a result.
I just think that speaks volumes for somebody who's traveling is its own niche for them to decide they're going to be staff or they're going to be staff here. I think that's really fantastic.
Yeah.
I credit Janine with us moving to WHSN and she credits me, so.
Well, you said I want it done by January.
And you did.
You say jump, I say how high.
Yeah. But that's just, in a nutshell, what that is we used to have every mayor would contract for their own agency labor, and one manager, Cody Staub might have 8 different contracts with 8 different agencies for trying to secure temporary nursing. And now we have one contract as an institution with Washington, WHSN, Washington something service. Yeah. Yep. And that's a product of the Rural Collaborative. So the Rural Collaborative stood this up, and then all those agencies can contract with WHSN, and we only contract with WHSN. Then we get one bill now from WHSN, and we don't negotiate with 14 different contracts who are all trying to negotiate. And they all talk to each other too, and they're like, actually, don't give them a nurse unless they increase their fees 5%. So they would like internally try to hold us to increase our rates all the time as well. So it's been a huge improvement. Well, bumps off the start, but it's been great.
We gotta give credit to Pam Lutz, who was really instrumental in getting that off the ground, Jen Strader and Ginger McIntosh. Those 3 really, really worked hard to actually get it up and running. It was a lot of data conversion, it was a lot of training for the managers as well. So they were really instrumental in actually getting it off the ground.
2 other things, just want to give a call out because I was looking at Cody's presentation. ER nurses having average of 20% turnover, or ER 23%, I think is what his thing had. We're at 7.8% in her Janine's 1-year review for nurses and 15% total. So we're pretty below those national averages. Too low is a little scary. Don't want to be too high.
Any other questions for Jean? All right, thank you. Moving on to operations, does anybody want to handle Holly's report or? I do.
I can just comment on a couple of things and welcome others to chime in for the work that she's been doing. She had to jump on a flight today and be out of here, so she apologizes that she can't be at the board meeting tonight. But something that's been really exciting that's been brought to KVH from a few people sponsored here from imaging and the ER is the Viz AI. And we've had some really good early patient stories that have come out of our Viz AI product. So Dr. Thomas would be the best to speak to exactly what Viz AI is, but it's something where we can care for stroke patients much quicker and get them the care they need a lot faster. But I want to give a couple of stories that Dr. Schmilza shared.
Viz AI is a tool that uses an AI algorithm to do a preliminary scan on images for CT scans of the brain when patients come in with stroke-like symptoms. It is able to alert providers almost instantaneously. The turnaround time is under 2 minutes, which vastly beats a human read, even if the human being happens to be conveniently live at the side of the scanner. And with that AI alert popping up on phones, on watches, on the desktop app. It gives people the opportunity to intervene immediately when an opportunity for changing patient outcomes exists. So Dr. Schmelzer was in the office this last week describing several of our different catches that have been thanks to this new software. It's very promising, and we're hoping that as time goes on, we're going to have a wealth of stories of lives that have been positively affected by this technology here in our valley.
Yeah, we had one we were talking about. We had a preliminary read before the patient made it back from CT to the ER. So it's just that fast that they get it.
So the algorithm reads if it detects something suspicious, it's handed off immediately to a human to confirm.
Yes.
And what are the studies about false negatives? It doesn't say anything, but later we detect there was something. Better than a human sort of thing? Is that?
Yeah, those events certainly exist. The reality is there don't exist studies that we can refer to, and part of the problem with AI technologies is that they're constantly evolving.
Yeah.
So we are a relatively early adopter of this technology, and we would expect that success rates will improve over time. But according to anecdotal evidence from our clinicians who are using it today, it is both immediate or near immediate and highly accurate to the point where they have a lot of faith in it.
That's exciting.
Yeah.
Great.
But human eyes still look at it regardless.
To multiple levels. Yep.
Yeah, we're not depending on it for the
Nope.
read.
It's
It's,
an alert.
it's like an extra
Mhm.
layer of it, an extra
Nice.
on it.
Those alert gives a priority.
It points to the right area in the scan, draws your attention to it, allows you to easily identify it and make a decision.
And in this case, we're focused primarily on strokes is what we're talking about here. So if it detects it, then we can begin the procedures to counter the stroke is earlier than maybe we normally would be able to, just with the realities of having a human look at it first and the time it takes to do that.
By at least many minutes, if
Yeah.
not
Which-
tens of minutes.
As they say, every minute counts.
That's right.
Great. Stealing your own thunder from Holly's report.
Yep. That's all I had to comment on.
Okay, so
Questions?
anybody else have any other questions regarding Holly's report she submitted?
Is there an update on the MAC educator for Upper County? Said by the time of the board meeting that would be filled likely? Is it
I don't-
filled or still waiting with beta?
Okay, anything else? All right, moving on to Chief Ancillary, Rhonda.
My report's on page 24 and I don't have any updates other than what we have here, but I'm happy to take questions.
Any question for Rhonda?
I had a quick comment. Were we planning to go visit Midtown Depot as the commissioners plan to do a walkthrough of Midtown Depot or anything?
We're planning an open house. I'm working with Crystal on that. We're hoping for sometime in March, and it's just hard to find a date that works for everybody with spring break and people still on vacation, but I am working with her to get that scheduled quickly. Unless you want to see it prior to that.
No, it's
Yeah,
all right. It's a nice opportunity when something like this happens for Hospital District 1 commissioners to get together with Hospital District 2 commissioners, to reinforce the relationship and sort of see what's going on up there. But I know it's hard to coordinate everyone's schedules, but that would be something that might be nice. I'll just put it like that. Thank you.
And we will also be inviting the foundation and of course all the therapy offices around as well. There's lots of therapy offices in Cleveland, so we want to make sure that they're invited to see the space. Looking forward to it.
If you are interested in a private tour, though, we can do that and then coordinate it with the board as well, outside of just the open house, and we can invite the other district too.
I think we can explore that.
Yep.
Yeah.
Thank you, Matt.
Thanks, Matt. Any other question for Rhonda? All right, thank you. Stacy, Chief of Clinic.
Yeah, my report starts on page 25 and goes through 26. Just to point out at Rapid Access, we've all the respiratory issues going on. The busy days, we easily see over 50+ patients, and a majority of the diagnosis right now are respiratory issues we're seeing. So it's great that we've got the third provider. So we've got 2 providers in Monday, Tuesday, and Friday.
Great. And so our lab it detects these various viruses. We can do it in-house here and so forth. And I was going to ask, do we also have the ability to detect the measles? Our system,
It's sent to the state lab.
okay,
The state wants to hold that responsibility.
okay. And it's a little longer turnaround time then obviously for that. If it's
Correct.
gotta be shipped out, okay. And how are we keeping our doctors safe over in Rapid Access if they're seeing so much of this?
They mask. That is one group that consistently masks.
Yeah.
Because that's all they see.
And have we peaked yet, or do you still see it on the upward?
We've always peaked flu season, respiratory season. So 40, I think, is some of our higher numbers we've seen compared to other times. I also know I'm starting to hear from patients, oh, you don't know about rapid access? Let me tell you. So word is getting out and we're starting to see some new patients we haven't seen in that area before.
And if somebody comes in and it is the flu, really, there's no treatment other you just advise them you have it, go home, fluids, all the other things that go along with it and whatnot. So
I will defer to the doctor.
It depends on timing. Yeah. So there is a specific antiviral regimen which has to be initiated early in the course. We do certainly encourage patients, especially those patients who are at high risk, to be tested and in a timely fashion so that we can start that antiviral regimen soon. And if they do, there is a reasonably significant improvement in their course.
and if people got the flu shot here, that's helping? I mean, it's never a perfect match, but
Yeah. This year it has not yet been a particularly helpful vaccine for the flu that we have circulating in our community. That doesn't mean that it won't become a helpful vaccine.
Yeah.
And we certainly are making some subjective assessments that individuals who have been vaccinated have seemingly had shorter courses or lower incidence, but it's not mathematically as helpful as previous years.
Thank you. Anything else, Stacey? You want to point out?
Open to any of the questions.
Any questions? Matt, any questions for Stacey? Good, thank you. Good. Moving on to medical staff. Chief of Staff, Dr. Hoppy.
Yeah, hi, good evening. Can you guys hear me?
Yes.
Excellent, excellent. I think my report is on page 27. And the Medical Executive Council, we were able to review files this month, and we had 4 initial credentialing files for consideration and 12 reappointments, and then 2 providers that we added additional privileges to, and that was mostly ultrasound privileges for ER providers. Other than that, I'm happy to report that we're making good progress on the bylaws. Dr. Beard, Dr. Thomas, and I and Shannon met last week, or this week earlier, and we're making good progress. So we're on track to hopefully have those approved soon within either first quarter or second quarter of this year. So
Excellent.
Happy to answer any questions.
Any questions for Dr. Hoppy? And go ahead.
Well, I was just wanted to move for this.
Okay, so we have the credentialing file. If you've all looked at them, we'll entertain a motion when ready.
I move to approve all 18 of these that we, all the commissioners reviewed also, and everybody else.
Motion by Terry. Is there a second?
Oh, second.
Second by Erica. Any further discussion? All in favor of approving the credential files for this month, say aye.
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 I too will vote aye. Any opposed? That motion passes. Thank you, Dr. Hoppy.
Thank you.
All right, moving on to Chief Medical Officer, Dr. Thomas.
Thank you very much. My report begins on page 28, goes for one more page to 29. You will notice some patterned similarities to the report from 2 weeks ago. I'm happy to entertain any questions. I have no additional updates.
That's how it is. Any questions for Dr. Thomas?
No.
Okay. Thank you. Appreciate it. And that brings us to the Chief Financial Officer, Jennifer.
Good
evening.
And if you could pause for just a second, I think we have a packet to finish up the financial stuff. I'll hand that out real quick.
Thank you.
All right.
Okay, so my report begins on page 30. And really, I think you know that we keep the books open as long as we can at the end of the year, just to make sure everything's accurate and right. And the financials that you have are also preliminary.
So normally at this meeting, it would be the closeout of the previous month. This being December, we're keeping them open as long as possible to clean stuff up.
Correct.
So this is the one time a year where this isn't necessarily the final for that.
That is right.
Okay.
And so what you'll see is after the audit comes, you'll see this financial statement, the audited statements, and any differences between. I don't expect a lot of differences this year. We do have a few accruals and maybe some movement around. But the one thing I do want to call out is that we did gain some ground last month towards our year end percentage, and are sitting at 2.15% for year to date, as opposed to our 2.7, I think, budget. So we did make some progress. So that was good. As I said, I don't see a big Medicare cost report settlement or anything like that. So I expect them to stay pretty close. The one thing that I would like to talk about is the master facility plan presentation you had. If there are any questions for me about that. And if not, we would love to have the board approve administration to go forward in negotiating terms of getting that master facility plan done.
And do you want to continue with any financials, or do you want to address this first?
It depends if you want me to walk you through the financials or not.
I don't need to. I'm on the finance committee.
We're going to, but I will.
But I'm not sure if anybody else has any questions. We certainly don't have to, because we have a lot of stuff to cover later tonight too.
I
So
really just wanted to point out where we are at the end of the year, and that I don't expect a huge bunch of change, but I will definitely go.
So not only we just met 2 weeks ago in here, do any of the commissioners want to hear more nuance of the finance report, or do we want to move forward to the discussion related to the presentation we had earlier? Does everybody feel content to move forward? Matt, thoughts?
I feel content to move, I feel content to move forward. Was there some more financial information that was distributed just now in a hard copy?
Yes.
I tried to email it to you before the meeting, but the email was down, so I wasn't able to.
Okay, if one of you could just email this to me, I don't need to deal with it right now. I just want to make sure I can review it.
I'll get it to you.
Thank you. No problem. I'm happy moving on then. Thank you.
Thank you.
I always just try to re-explain at the end of every year, just the reasons why we keep the books open a lot longer. You explained it, but I think just try to put it in real non-accountant terms.
Was I talking?
I don't know. I'm joking.
I thought I was.
Don't we ask
speaking
questions?
English.
So we want to let as many invoices trickle in as possible.
That attributed to last year.
Attributed to 2025, and then we can expense them to 2025, because once we close the books, we cannot open a prior year. And that's when, once the books are closed, all that data goes to our auditors. Can't open the prior year except for audit adjustments. So gives us time to let all those invoices trickle in, get a lot more accurate estimates. So we always estimate things like agency labor for the prior month, prior few months. This gives more time for that agency labor to actually invoice us, get actuals in, and hopefully have very minimal audit adjustments. So trying to
Very minimal. Very minimal.
very low. Typically, we have pretty low audit adjustments for cost report.
Maybe just touch on the net and stuff for the month where it currently stands.
Okay.
We have positive operating margin.
You got it.
Yeah, this is the high level stuff, Matt, that wasn't in the report you got.
So we'll just skip right to the statement of revenue and expenses, which I don't know which page it is, but it's after the dashboard. And just ended up the month really nice at $534,000, which was a good deal over our budgeted number, which is what brought us up to 2.15% in our operating income year to date. And net income bottom line, really nice at $7.1.
And almost $1 million for this last month.
Correct.
Yeah, so
It's a good deal.
positive numbers.
Positive numbers all around.
Good. And we'll get you the full report.
Sorry
after
about
meeting.
that, Matt.
Yeah, well, no, you were, it was only 2 weeks we last met. It's a lot from a financial standpoint to get ready in 2 weeks. So we appreciate it. No issues.
That
Also,
they just go through a whole balance sheet and just make sure all those numbers are
Yeah.
absolutely accurate.
Go ahead, Matt.
It sounds like I didn't get it just because email was down. So the person to blame is Jeff, I think.
There we go.
Yeah.
All right, so we turn to the discussion of the master plan. Is there anything you'd like to add to his presentation?
Well, not really. I just have experienced master facility plans with other architects and also with this architect, 2 different hospitals. And their process is just so inclusive and they're just so knowledgeable about what's coming in critical access. They work mostly with critical access hospital. And maybe Stacy was there during their process up in Cleellum, if she wanted to speak to it. I just think it's
But
necessary.
just so I'm clear, you've worked with them twice before, is that what you're saying?
Twice.
So you've gone to the finish line,
Yep.
you're happy with the product and the process? and-
Absolutely. And as he said, they're a resource. I can call them any day and say, what's this? And they're just a really good resource. And
I can say in working with it for FMCE, they really sat down and listened to the staff and asked questions and took amazing notes for feedback. And then we kind of walked away for a little bit and in the afternoon, they had something already drawn up for us and said, here's kind of what we're thinking. So how does this sound? Is this what you were telling us? So they're very engaged and that we brought providers, PSRs in, MAs, the clinic manager, and they listened to all levels of staff for feedback.
And,
What-
go ahead, please.
And what they delivered was appropriate.
Yes, absolutely. It was really refreshing to see.
Okay.
And these staff members that participate, they do it willingly and they're
Yes,
kind of,
yes, they were.
we've heard as a positive thing.
Yes, they were really excited to talk directly to the architects.
So they're kind of sharing their needs, like in an ideal world, this would be great sort of thing, is that?
Yes, that's what they were sharing.
And are they gonna do this for all of our properties? I mean, basically a global thing of
Yep.
everything?
And our empty properties.
yeah,
But
the feasibility.
Empty all the way down to just bare land?
Yep.
Okay.
And
Cows.
first would be a mechanical infrastructure, because we know we've got roof stuff and chiller stuff and boiler stuff. So really an analysis of where do we stand right now? They're very well aware of that. They have a guy that comes, they'll come for probably a week and a half, I would imagine. And just meet with every single department leader and staff who want to be there. And I just, like I said, I've been through other master plans and I just would take them home to my mom if I could. I just love them so much. But anyway, I think it's really a necessary thing for us to do as we look at growth and try to be a little more or a little less chaotic in our moves. I would like that, but anyway, that's all.
So board members, do you have other questions about what we're trying to accomplish here with this?
Seems like such a daunting process, but I'm glad there's people who specialize in it.
Matt, do you have any other questions about this process? Okay. do any of the other members here have any concerns about this? And yeah, please.
Just a comment, as superintendent of Hospital District 2, I want to make sure that we are getting their approval as well, that this is the architectural firm that we want to work with or for planning. I just don't want to leave them out of this process.
What's the best way to do that under these current circumstances, do you think?
I think we would need to just put it on the agenda for maybe the next board meeting and get their buy-in on it.
And when,
But they know that that's coming.
Mhm.
Because we've been talking about that, but I don't think they've had any opportunity to meet with them or have any type of a presentation.
Okay, that's very helpful. And do you know when their next board meeting is scheduled for?
February something.
Middle of February. Yeah, so
We
I've
just
been
made
under
up
the consideration to, we'll work with them for any improvements that are due to the building. Obviously, not necessarily choosing the architect. That is District 1's choice. But we can't make any changes to their building without their buy-in. So that was the presentation I intended to bring on this. This is what we're looking at, the building and facing, not architect rules.
It's interesting because it's their building, so it seems like they would have a voice in that, and I don't think they'll have any objection at all, but I just want them involved.
Definitely. And so what do you feel we can move forward with today? I mean, because it sounded like you wanted to be prepared to negotiate with them and.
Yeah, and they've already looked at Cleellum, so I think we're at a point with Cleellum where we go to the board and say, you know, this is kind of a schematic plan, it's a real draft, and are you interested, or whatever it is. The rest of the facility.
Don't we have as our architect on record that we're using KDA for Hospital District 2,
This isn't District 2 using architect, this District 1 using architect.
where they're building?
Right. District 1's paying.
But they don't have to use them, and
I don't think they'll
and
have
they
any
don't even have to
objection.
be part of, I mean, Cleellum doesn't even have to be part of this, because they've already done that in Cleellum, so I think, you know, that's what I have to say about that.
Rhonda, are you feeling like you've been heard? Because I appreciate your concerns.
Well, I guess I would want to take that to our board president and make sure that he is in agreement. And I think he will be, but I think out of respect for him, that I should have that conversation.
Yeah. And from a timely standpoint, is this, you know, are we under pressure to get started on this? Do we have time to wait for another board meeting to hear their input before you finalize what you do? Or does hearing from them impact what you're trying to do next, or what you're asking us to approve tonight?
We still approve engaging with JJCA, and the administration will work with Hospital District 2 and with their board to ensure
Okay,
agreement.
good, thank you. So do you need a motion from us? What are we looking for?
I don't know.
Yeah.
Looks like we do.
Motion. And what would the motion say? Tell me what the motion says.
The board to approve administration to negotiate terms and enter into a contract for a master facility.
So we have a suggested motion from leadership there. Would anybody like to make such a motion?
I'll move.
Okay, motion by Bob.
Second.
Second by Matt. Is there any further discussion? Hearing none, all in favor, say aye.
Aye.
I too will vote aye. No one is opposed. That motion passes. Thank you for the presentation information on that tonight. Appreciate it. Do you have anything else for us?
No, unless you have questions.
Any other questions? Okay. Hearing none, we will move on. We don't have anything under education or board reports. We don't have anything under old business or new business. So that'll take us to executive session. Let me read this first. Go into executive session. We'll have a discussion with legal counsel about current and potential litigation and the legal risks of current or proposed action, RCW 42.30.110, subsection 1, subsection I, and to evaluate the qualifications of an applicant for public employment or to review the performance of a public employee under RCW 42.30.110, subsection 1, subsection G. So it is 6:29. Why don't we take a 5-minute or a 6-minute break to 6:35? How long do we need for executive session, do we believe?
I planned for an hour.
Okay, so at 6:35, we'll have a 1 hour executive session and we'll extend if necessary at that time.
And I'll ask just Rhonda and Jennifer and Dr. Thomas optional to stay.
Okay, thank you. So other than that, we will go into executive session after a 6-minute break.
Is there action anticipated?
Is there action anticipated afterwards?
No.
No, at this point, no. So thank you everyone for attending and we will go into executive session shortly.
Thank you.
Thank you, everyone.
2 weeks again on February 16th.
Perfect, thank you.